Good afternoon. My name is Jason Helgerson. This is my colleague, Kalen Scott, and we're here to talk about the Medicaid Redesign Team. It will require alchemists, not policy wonks or providers, to transform cuts of this magnitude into gold. That was what Dan Sisto, the head of the New York Hospital Association, told the New York Times as the Medicaid Redesign Team was being launched in 2011. That was what most observers thought about a new process purported to generate both immediate budget savings and develop a reform plan for the nation's largest Medicaid program in the teeth of the worst budget crisis in state history. In 2011, New York Governor Andrew Cuomo decided to pursue a novel approach to Medicaid reform by inviting stakeholders to the table to have a say in their future. The implicit threat was that if they didn't roll up their sleeves, he would move forward and make sure the budget was balanced. The governor said there were no sacred cows, everything was on the table, with the only exception being that benefits for vulnerable people could not be cut. To the surprise of many, and the process actually worked, and I'm here to tell the story. Like most states, New York's Medicaid program was approximately 1/3 of the total state budget, and spending was $50 billion a year annually. And it was growing at an unsustainable rate that was putting the entire budget at risk. Each and every year, it gobbled up ever larger portions of the budget and at the expense of other priorities. Historically, the annual budget process in New York was a political mess. Governors would propose cuts, which would be bitterly opposed by the healthcare industry. Decisions on Medicaid spending were made behind closed doors, and meaningful reforms rarely advanced. A novel approach was clearly needed. Surprising to many, the MRT, including Mr. Sisto, coalesced around recommendations which fundamentally changed the program's trajectory, while at the same time preserving those important benefits for vulnerable people. For the first time, stakeholders collaborated and developed a plan that actually lowered costs and launched reform. The fact that this novel approach worked in a politically challenging state like New York shows that it can be replicated in other jurisdictions and sectors as well. Stakeholder engagement is the key to MRT's success. The MRT brought 27 key stakeholders to the table who committed to work together to develop a reform plan in a transparent manner. The MRT pursued an even broader stakeholder engagement strategy, including public hearings all over the state with opportunities to submit suggestions online. That process generated 4,000 ideas in less than 2 months. The MRT established 10 work groups to pursue comprehensive reforms that brought together an additional 175 stakeholders who brought their expertise to the table. Engaging stakeholders and developing a reform plan was only the first of MRT's successes. To ensure that the MRT's work wouldn't go to waste, the proposals that were advanced needed to be successfully implemented. To achieve this, a rigorous project management system was deployed. Every one of the more than 230 projects is tracked and progress is regularly posted to the web. Coordination of project implementation across state agencies and the efforts of hundreds of state staff contribute to the success. Other components of the project management process include detailed fiscal tracking and interactive visual data mining, which together allows for the analysis of healthcare outcomes related to each project's implementation. This was accomplished through a partnership with the New York company Salient, who brought the high-end analytics to the table. How do we know the MRT was effective? How do we know that it was significant? The independent New York State Comptroller's Office found in a March 2015 study that the MRT restrained Medicaid spending growth to only 1.7% per year, roughly 1/3 of the 10-year annual average of 5.3%. What makes this result all the more amazing is during the same period of time, enrollment in the program grew by more than 500,000 people. This result means that billions of dollars have been saved and per recipient spending has been slashed. In fiscal year 14-15 alone, $16.4 billion was saved thanks to MRT. This track record of success led the Comptroller's Office to declare that the MRT, quote, represents the most comprehensive restructuring of New York's Medicaid system since it began in 1966. CMS, the Center for Medicare and Medicaid Services, also recognized this achievement and rewarded our efforts by reinvesting $8 billion in MRT savings back into New York's healthcare delivery system. The success of MRT shows that it doesn't require alchemy for government to meaningfully engage stakeholders, to deploy aggressive project management and use the latest in advanced analytics to improve program efficiency in ways that are politically doable. It also shows you can ensure financial sustainability of a large entitlement program without taking benefits away from vulnerable people. Thank you very much for the opportunity to present the MRT story here today.
Thank you. Do you have any questions? Yes.
Oh, yeah, one question, that's been asked is, with the bar, so, by your own account, the bar, was pretty low. The situation was pretty bad that you took over. Is that to say that, it's easy to make progress where you're starting from such a low point? How do you answer that?
I would say New York's Medicaid program, which was the nation's largest, as I said, average annual expense of over $50 billion. We had a per recipient spending level, which was about twice the national average. So we were in a very inefficient program in terms of most of our outcome measures, which suggest we were generally middle of the pack. So in terms of level of investment, we had a long way to go. That said, we also work in a very difficult and challenging political environment, a political environment that had vexed multiple governors before. And in fact, there was a recent article in the New York Daily News that described the Medicaid redesign effort as Cuomo's silent Medicaid miracle. And the reason was that very few people thought that this program could, in fact, be reined in, that there was a way politically to survive reductions in spending, achieve efficiencies, and we had quite a few years prior to MRT where those efforts were attempted but failed for a variety of reasons. So I think while, yes, we had opportunities for efficiencies, the political environment made that challenging, but MRT really sort of changed the political dynamic, which was a key to the success.
How critical was having a leader who could set the tone and create a sense of urgency, a burning bridge, if you will? You know what I mean? Like the...
Leadership is absolutely essential. Prior to my becoming the Medicaid director in 2011 in New York, I was the Medicaid director in Wisconsin, and we had a somewhat similar process, not nearly as developed, to also address a very difficult budgetary situation there. And the same was true in the sense that the governor in Wisconsin, like Governor Cuomo, had to make this a priority and display leadership. And on a budgetary issue as significant as Medicaid, third of the budget, the chief executive has to play a prominent role, and Governor Cuomo played a very prominent role in making sure this was a success.
Yes, Pete.
Just to piggyback on that, the importance of how bad things were and the dramatic sense of the cuts that were asked for aren't, again, to the question of transferability, aren't they necessary to drive some of the creativity that you all had? If there were other Medicaid, Medicare systems that were not in the dire financial situation that you all were, would some of this be as possible?
I would say that we are far from our last recession. We will have another recession at some point in the near future. And with our balanced budget requirements in every state, governors will be faced with the same dilemma, which is difficult budgetary situation, programs with tremendous complexity, but a need at the same time to generate savings, to live within the balanced budget requirements. So I think that in whatever situation, whenever those challenging budgetary or financial circumstances exist, I think the model can be effective. But I think governments across the country at all different levels face budgetary challenges at various points. And I think that this process could be used in any of those circumstances, in not just in healthcare, but in almost any program area.
So just a quick follow-on then. The interaction you had with CMS, you mentioned that they had made the decision to take half of the savings and plow them back into delivery. What has been the relationship more broadly with CMS and their ability to communicate some of the points and things that you've done here to other states?
Sure. We give the Obama administration a lot of credit. When we came in 2011, we had this huge budgetary challenge. They allocated specific staff people to work directly with us to give you a sense of the challenge, and for those of you unfamiliar with Medicaid, most of the time when the state changes a policy, it also requires federal approval. It takes different forms. But the most common federal approval is what's called a state plan amendment. We had about 130, 135 state plan amendments pending with CMS, and they had to be approved in a very rapid fashion because we had to generate all of this savings. That was more state plan amendments pending with CMS by one state in the history of the Medicaid program. So we literally were trying to change more things simultaneously than any other state had ever tried. So CMS really worked with us very carefully, very closely, and we got expedited approval for a lot of these changes. And if we had not had that good partnership, it would have made achieving the level of savings we had to get very difficult.
Thank you.
Have you seen any data on health outcomes? You mentioned a moment ago, New York was middle of the pack.
Yep.
High cost, middle of the pack.
Yes, so we track our outcomes, particularly in our Medicaid managed care plan, very closely. And so we've been actually tracking them for well over a decade. So we have a base of data to look pre and post. And we recently submitted for publication, it hasn't yet come back to us in terms of it, but the publication suggests that we have either maintained or actually improved outcomes throughout the 4-year period of Medicaid redesign. So we certainly have not seen a regression. That was certainly our goal, was not to see the quality of care. And I think part of also was that Medicaid redesign was not just about cost containment, but also about launching meaningful reforms. So we actually, in all of these initiatives, we have made investments. We've launched new initiatives designed to actually improve outcomes for patients. So it was about trying to do both, create space for both. So it wasn't always just about cost containment. So we feel that overall, the outcomes, as I say, have either improved or at the very least been maintained.
Well, I thought I loved talking with you last night because I asked the specific things. What were the things that you saved money on? And if you don't have other questions, I love you to describe the OBGYN and the home health care cost savings and the revolving door on the mental health issues, because that relates to what we had heard from Carolyn earlier.
Sure. So in 5 minutes, we're unable to talk about all the initiatives. But in the first wave of MRT, that first plan that was developed in basically about a 2-month span, had 79 initiatives. Of those 79, 78 were approved by the legislature, some with some modifications. But generally, the plan that the MRT developed went into law. And of those, there were a number of initiatives, some ranging from very large to some to very small. One of the larger initiatives was we had a home care program, particularly in New York City, that was costs were out of control. The previous 5 years, the spending in the program had doubled, yet the number of people served by the program declined. That is not a recipe for financial sustainability in any government program. So we enacted a 2-phase approach. First was the program was in a cost-based reimbursement, which incentivized ever-increased hours regardless of acuity, and we showed very definitively that the link between the need of the patient and the hours provided had been totally lost. So we enacted a rate change, a methodology change that incentivized hours to be adjusted to acuity. And then the second phase, which we've now completed, was to move all the services from fee-for-service to managed care, where we have organizations that are accountable to the state for not only lower costs, but better patient outcomes. That one initiative alone saved about $300 million a year. Another major initiative was pharmacy spend, which the pharmaceutical costs for any Medicaid program, one of your top cost drivers. And that was a fee-for-service expense. While most people were in Medicaid managed care plans, we excluded the drug benefit. We had about a 67% generic fill rate. We moved that drug benefit on October 1st of 2011 into Medicaid managed care. We drove up within about 9-month period the generic dispensing rate to 80%, with very few problems around customer satisfaction. And that one initiative alone is saving us now $425 million a year. So those are just 2 examples, but those are just 2 things that we have launched as part of this that continue as how the program operates today.
So without getting political, you can bend the cost curve, get more efficient without throwing a lot of people off Medicaid?
That's correct. Yeah, I mean, that's our goal.
Had to get that in, sorry.
Yep. But I think that, and Mayor, as someone who ran a Medicaid program, you know the challenges in any state or in the case of the district's budget that Medicaid is. And I think states across the country are having these
a big
questions
issue,
about, can you sustain this program and not cut benefits or cut rates to providers sort of across the board and those things. And this was really a process to sort of avoid all of that. Could we actually achieve efficiencies and at the same time launch initiatives to improve care for patients? And certainly,
Right, even beyond Medicare, Medicaid, or Medicare for that matter too, can you just generally actually reduce costs? And you're showing that you can. Right,
Yes,
that's a
I
big deal,
absolutely believe,
as
absolutely
President Clinton
believe
would
that
say, yeah.
we can make entitlement programs sustainable without taking benefits
Right.
away from vulnerable people.
Right.
All right, on that note, thank you very much.
Thank you.